Well, good afternoon, FLaNET community. Thank you for joining us. And as more join, we will let them into the room. We are going to get started, and we have the next hour together. Thanks again for your time. So I'm Dr. Mena Hyder at Moffitt Cancer Center. I'm joined by colleagues who are here to support our educational efforts in our community. Dr. Jason Starr from Mayo Clinic, Dr. Aman Chauhan from University of Miami recently joined us from Kentucky, so we're so happy to have you here. And my colleague, Dr. John Strasberg, we work together at Moffitt. Before we get started, I want to remind everyone that we have an in-person meeting in Miami in January, so please look for the save the dates that are on the website and emailed to you as well, with more information forthcoming. So our goal today is to share what we have learned at our annual NANETS meeting. There are some new medications near on the horizon, with other efforts to expand radiotherapies and systemic therapies. So starting with you, Dr. Starr, can you share some of the new symptom management discussions that we learned about?
Absolutely. Yeah. So first, thanks for having me. I love this initiative, FLaNET, and I love that we have such a, great consortium of, specialist experts here in Florida, to be there for our patients. It's awesome because sometimes patients have to travel wide and far to try to find, physicians and providers that are well versed in this disease. So it's great to have so many resources in Florida. So as far as in regards to symptom management, a few things on the horizon that we kind of talked about at NANETS and what kind of I learned a little bit more about. So one thing we should point out is in terms of symptom management, carcinoid syndrome, right? We talk about a lot. But one thing that we should point out is, all diarrhea is not related to carcinoid syndrome, right? Classically, carcinoid syndrome related diarrhea is due to elevated serotonin, and we can measure that we can measure that with a test that, you may have heard of called 5-HIAA, which is essentially the metabolite of serotonin. We used to measure that in a 24-hour urine collection, and thankfully now patients don't have to carry around jugs to collect urine over 24 hours and can do a blood test at one point in time to get an accurate measurement of that test. So as it relates to diarrhea, one point of emphasis that I really liked that Dr. Havdanerson had pointed out during his kind of year in review. Dr. Havdanerson's my mentor. He's up in Mayo Rochester and the incoming president for NANETS. And he pointed out that an overlooked cause of diarrhea is bile acid diarrhea. Right. So many patients, right, the most common place that we find a neuroendocrine tumor in the GI tract is the small bowel and typically the terminal ileum, right? So if you have surgery and you remove the terminal ileum and the right side, sometimes the right side of the colon, this is where bile acids are reabsorbed and recycled in the body, right? And so if the body doesn't have a mechanism to recycle these bile acids, they come kind of rushing out in the stool. They're cathartic, they're acidic. And so it's very underrecognized where patients are having diarrhea, and there's a really pretty easy fix, which is something we call a bile acid sequestrant. And typically these are taken once or twice a day. And what they do is they bind up the bile acids, neutralize them, so they don't cause the diarrhea. I just had a patient the other day with this, and had been grappling what's causing the diarrhea. I started somatostatin analogs and it made my diarrhea worse, which they can, paradoxically. So you're kind of chasing your tail in that sense. There is a blood test that you can do for this, a bile acid diarrhea. It's called a 7-AC4. And essentially what it is it is a byproduct of bile acid synthesis. And when this is elevated, it means that your body is not recycling bile acids efficiently. And so sure enough, in my patient, it was elevated. We had already started the bile acid sequestrants and it was getting better. So I think that's an important cause of diarrhea to point out that's not related to carcinoid syndrome. So let's circle back to carcinoid syndrome. There is an oral somatostatin analog that's on the horizon. Crinetics Pharmaceuticals is developing it. So I believe Dr. Strasberg has this trial available at Moffitt. They have it at Mayo Rochester, but essentially it's an oral somatostatin analog. Like patients get injections, once a month, or for the short acting ones, you're doing it, every 6 hours or so, or every 8 hours, based on symptoms. And this is a pill that essentially would supplant the long acting injection. So sounds nice. It's a twice a day pill, which seems feasible. So that's on the horizon. Another drug that's on the horizon that we should be on the lookout for, related to treatment of carcinoid syndrome and the disease otherwise, because just to take a step back, when we use somatostatin analogs, we're using them for a twofold approach, right? One is sometimes for symptom relief related to carcinoid syndrome, but one is for disease control, right? It's usually our first medication that we use for disease control in low grade, well differentiated neuroendocrine tumors. So historically, we've had the choices of lanreotide, right? And we've had octreotide, LAR. And these are tried and true. The octreotide LAR, as we recall, is an intramuscular injection. The lanreotide is a deep subcutaneous injection, which pretty big needle. And those have been the ways that we've been administering these somatostatin analogs for long-acting relief of either carcinoid syndrome or for disease control. So as I mentioned, we have the pill, somatostatin analog pill, which is really being studied for carcinoid syndrome right now, not necessarily disease management yet. But there is another formulation of a somatostatin analog, which is called at this point CAM 2029. It's through Sorrento. The trial is called Sorrento. The drug company is called Camurus, Camurus, and we have this trial available here at Mayo, and you all have it, I believe, at Moffitt, and I'm not sure if Dr. Chauhan's group has it down in Miami. I believe they do. And it's actually about to wrap up. But essentially, in a nutshell, what this drug is a subcutaneous injection of the somatostatin analog. So we talked about the deep subcutaneous, we talked about the intramuscular. Well, this is a smaller needle, thinner needle that would be injected essentially in the belly fat, and be given every 2 weeks, and could be potentially done at home, which would be so wonderful for patients not to have to travel, go to the hospital, park, valet their car, make a whole day out of it, but instead in the privacy of their home. So that the way they're doing it on the trial is patients are randomized, so meaning some patients are assigned computer generated to get the standard, what we've been doing. Some patients are assigned to get the study drug, and they do a few sessions of this injection, 2 or 3 in the office. And then once they're taught, the patients can do it at home. So that's a wonderful new development. That trial accrued really quickly internationally, and is almost finished accrual. So we may have yet another option for patients. More options are almost invariably better to have more options, right? So those are some kind of new developments in regards to disease management, symptom management. I emphasize the bile acid diarrhea as an often overlooked cause of diarrhea in this patient population.
Thank you. I agree. Diarrhea really is multifactorial, and a component of it could be side effects from the actual NET treatment. But it is very exciting because we've had somatostatin analogs for many, many years, and now that first line treatment, if you will, is expanding and maybe providing some independence from the clinic and the monthly visits, so that our patients can kind of have a more freed up personal schedule and maintain their clinic. We want this to be very interactive, so please unmute if you have a question. If you raise your hand, I can call your name, or you can send us questions on the chat.
Yeah,
I'll
we're here
pause.
for you. So absolutely, please don't hesitate to ask questions.
While you gather your thoughts, Dr. Chauhan, Dr. Strasberg, any comments about these new upcoming medications?
Um, So I'm actually very excited about that there is drug development happening in this functional net space, because often a lot of research focuses on tumor control, which is important, but unfortunately our functional nets patients get sidelined. So I'm glad that the industry is thinking about finding alternatives to the current deeper injectable, deep intramuscular and deep subcutaneous injectable. We are involved in the oral somatostatin analog paltusotine study, and uh, hopefully you will see some early data next year. But again, I think it was a huge clamor from our community regarding finding an oral or a transdermal, approach where people who don't like needles want an injection and can rather take pill. So I'm glad that we are investigating that. I'm also very happy that my colleagues, Dr. Strasberg and Starr, are investigating the subcutaneous version, which can be easily done at home. Like our European patients can get these long-acting somatostatin analogs at home. They don't have to get it at hospital or healthcare facility. So I think that really is very restrictive for quality of life for our patients. So I'm glad that we are looking into those alternatives as well. So more options, better for our patients.
I do have to take a moment that we did not open that trial here at Moffitt, but we are very excited to see the outcome through with our colleagues who are able to participate. So, Dr. Strasberg, do you see the future kind of shifting from what we're using now? If these studies are positive, that we'll kind of leave behind these monthly approaches?
Yeah, so the oral is for patients, is looking at patients with carcinoid syndrome. And I think it's a very interesting drug. It's going to be hard to know to what extent it also inhibits tumor growth, because we have very good evidence with sandostatin and somatostatin that these drugs both inhibit tumor growth. We won't have that evidence with the oral somatostatin analog. Nevertheless, I think it'll be reasonable to try it in patients who prefer pills to monthly injection, especially if if their disease burden isn't very high, and they can always switch later to the injectable drug if they have progression. As far as the Camurus drug, it's a pretty ambitious randomized trial. It's trying to demonstrate that it's actually superior to lanreotide as far as inhibition of tumor growth, is delaying time to progression. I'm not sure that it's going to be able to meet that endpoint. Of course, we won't know until the trial's complete. But what they're saying is not only that it's not inferior, but actually it's superior to the existing drugs. And we'll see what the results show. I think if it's a positive trial, that'll be great. If it doesn't meet that endpoint, unfortunately, it probably won't be approved. So we'll have to see what happens.
Good point.
All right, I didn't see any questions come through, but we can always come back to this topic. But staying on that receptor component for treatment for well-differentiated lower grade nets, Dr. Starr, another discussion that we wanted your comments on is the use of PRRT and expanding that class of medications, perhaps using alpha emitters. What did you see come out at our annual meeting that is important to share today?
Yeah, thank you. So, the alpha particle therapy is thought to be almost like the next frontier of peptide receptor radionuclide therapy, or PRRT. And what advantage does it have over what we have, right? So what we have is lutetium-177, also called Lutathera. It's beta particle therapy, right? And so beta particle is essentially the energy that's emitted from the radioisotope once it kind of is delivered to the cell, to the cancer cell, I should say. And so alpha particle therapy, the prospect and the hope and the promise that it delivers is that it's what we call higher energy transfer, linear energy. So it hits the cell harder, essentially. The radiation hits the cancer cell harder. What the majority of the damage that the beta radiation does to the cancer cell, right? So there's 2 strands of DNA in all of our cells, right? With 23 chromosomes on each one. And so we have the DNA that's sitting in the cell. The beta radiation does a single strand DNA break. So it damages one of the strands of the DNA. Well, the cancer cells, unfortunately, are smart. They'll more easily repair a single strand break than they would a double strand break, which is a little more difficult to repair. So it requires more, kind of more concerted effort. So the alpha particle therapy delivers a double strand DNA break. So that is I would say at this point, the theoretical advantage, right? We know that's what happens from a scientific standpoint, but does it translate to a better therapy than what we have? Because what we have is pretty darn good in the Lutathera. So the one trial that was highlighted at our conference and then subsequently also highlighted at the ESMO conference, which is our European oncology conference, is the Action 1 trial. Company is Raise Bio, and we've all been excited about this trial. And the compound or the radioisotope is actinium-225. And essentially, patients who have had progressed on our standard therapy, our lutetium-177 or Lutathera, and benefited though for at least 6 months, are eligible for this trial. And the trial is randomized in a 1-to-1 fashion. So there's there's a 50% chance that patients get the alpha particle therapy up front, and then 50% of patients get what we call standard of care. Standard of care can essentially be whatever the physician and the patient decide on as the next appropriate therapy for them. Okay. Now, the nice thing about this trial is there is something called crossover. So patients who were put on or randomized, I should say, computer generated, similar to the other study I mentioned, patients who are randomized to the standard of care arm and have progression on whatever that therapy is, are eligible to cross over to the alpha particle therapy. So it's nice to explain that to patients that they will have an opportunity to receive this therapy, because it's a big time investment and sacrifice to go on a clinical trial, right? And a lot of trust you're entrusting your team and your physician that this is the right choice for you. So we always want to kind of operate in the best interest of the patient to make sure that they're going to get an opportunity at this potentially paradigm shifting therapy, potentially, right? So we have the safety data for this alpha particle therapy, and thankfully it looks really safe in terms of very minimal side effects compared to what we'd already experienced. They had reported some patients having some low blood counts that seemed to be transient, but nothing emergent in terms of a new side effect that we weren't seeing prior with PRRT. No worsening kidney function per se, although they did see some decrement in kidney function in patients who had some impaired kidney issue. And then blood counts didn't seem more exaggerated than what you would expect from beta particle therapy. So the initial analysis of the 17 patients showed that it was safe. They saw 5 responses, which was exciting, about a 30% response rate in that patient population who had already received PRRT. So really exciting. Now, because we have the safety data, it's now kind of leaned into the phase 3 portion, which is what I had mentioned, the randomized. So that's up and running. We have it at Mayo. I will say it's a very complicated trial. It's international, and you have to reserve a slot for your patient. And they're now, the date to start the treatment is pushing out almost 2 months from when you want to start the therapy. So I think you have to be conscientious of that as the physician and the patient to know if you need a therapy right now, maybe this isn't the best option because it's just a lot of moving parts for the trial. And then briefly, there's another trial, which is an alpha particle therapy trial, which is LED-212. And this radioisotope, I would say, is not quite as far along as the actinium-225. They're in the phase 1 portion. So they're looking at safety and a signal of efficacy in terms of making sure it's safe first, because anytime we do a phase 1 trial, the primary goal is safety. We want to make sure it's safe. But we obviously look at efficacy. We get a little sneak peek, if you will. This trial is enrolling patients if they have the expression. I should have said that implicitly, that you have to have a certain degree of expression of the receptor, the somatostatin receptor, to be eligible for these trials, i.e. we do a PET scan. You can call it a bunch of different things, NetSpot, DetectNet. There's a bunch of different ones that we have available now, thankfully. And if that is positive, then you're eligible for these trials. The lead trial, you do not have had to have had the beta particle therapy. So a little bit easier to get on that trial. It's also not randomized. So if you go on the trial, everyone gets the therapy. But again, not as far along as the actinium-225, which is already in its phase 3 portion. Dr. Strasberg's leading, I think, the effort on the Action 1 trial. I think it was the first author on the safety data, at least, so he could speak a little bit more on that. But these are really exciting therapies, and we're hoping that we can improve upon what we have, not at this point necessarily supplant the beta particle therapy, but have something to build on. So I think that was a mouthful from me.
Well, what caught my attention is that we have a different way to deliver this technology that seems to perhaps have more of an impact, but in multiple points in therapy. So we're looking at it as a primary PRT for, as the first exposure, but even answering the question about retreatment with PRT if the first treatment was successful for our patients. So it's not only expanding the field of how many medications are available in PRT, but also the lines of therapy where PRT can be reused.
Yeah, and your point is good, and I'll let Dr. Chauhan comment on this. We also have a trial called the NET Retreat, which we spoke about amongst ourselves at NANETS, and we were excited because this recently launched. But Dr. Chauhan is leading that charge. Maybe, I don't know, that'll lead in maybe just to mention that trial, Aman?
Oh, sure. Thank you. Definitely, so Lutathera or PRT, the Lutathera is currently only FDA-approved PRT option in the US, right? And likes of Dr. Strasberg's and others were instrumental in getting access to this therapy. I remember when I was a resident at LSU, we used to send patients routinely to Europe to get PRT, right? And times have changed since then. I've personally overseen treatment of over 250 patient Lutathera since FDA approval, right? So it has been a game changer for our patients. However, when you have a treatment that effective, but it's only 4 doses, it's but obvious when patient progress several years down the road or several months down the road, they'll ask, hey, doc, this treatment works really well, very well tolerated, easy to do, limited doses. Why can't I try it again? So the original NET-1 trial studied only 4 one-time doses, right? So we currently lack data, prospective randomized data to support that, okay, we can re-challenge Lutathera at progression, and it will be safe to do it, and it will be also effective. We, however, do have data from Europe and various other single center retrospective studies to show that, yes, it is safe, because you do tend to have somatostatin receptors intact at progression in majority of patients. It is also effective. However, these data are not prospective, they don't have the rigor of what we do and need for a recommendation, right? And how does that impact you, me, and our patients? Because access to the care, right? So we can easily prescribe Lutathera at progression, but the payers, the insurance might decline it, right? It's not currently FDA approved, and these are very expensive drugs. So we really want access for these important medicines to our patients. So NCI and NCTN networks, both US and Canada, decided to kind of put together joint forces and see, okay, let's do this study and confirm that there is effectiveness in re-challenging Lutathera, and it's also safe to do. So this trial, the NET retreat trial, was born out of this concerted effort for all the people. You know, me and Dr. Simran Singh from Canada are leading it, but really it is a joint effort for 50 plus people, and all the NET experts and NET advocates are involved in this. This study is now up for the grabs. We are expecting that most US and Canadian sites will open the study, and hopefully next 2.5 years, we finish this, because this data would really get us access, expanded access to Lutathera re-challenge at progression, if this is a positive study. So very, very excited. Again, another option in the re-challenge setting is that Action 1 study, where we have the other type of PRRT, the alpha PRRT, right, at progression within 6 months after initial Lutathera. So very happy for the field, kind of looking at PRRT in refractory patients who've prior exposure to PRRT. I think that was the next frontier for us.
Thank you. So Dr. Strasberg, one of the discussion points whenever we're looking at what to use next together with our patients is, how do we sequence care? And it looks like that's going to become ever more of a challenge when we look just at PRRT, with so many options emerging, and even within clinical trials. What would be your approach, or how would you counsel your patients about that?
Oh, wow, that's a tough question. I mean, anytime someone progresses, we have to look at a number of options, which can include both whole body treatments like PRRT, like Afinitor or Sutent or chemotherapy, as well as, in many cases, liver-directed treatments like liver embolization. So, just as a general statement, we don't have many existing trials that compare two different treatments to each other. We have, trials that have compared drugs to placebo. The NETTER-1 study compared Lutathera to high-dose sandostatin, but we don't have a lot of trials that are comparing two FDA-approved drugs to each other. But we do have some that are taking place right now. So the Action 1 study is comparing actinium dotatate to one of several standards of care. There was the COMPETE study looking at lutetium DOTA-TOC, which is very similar to Lutathera, that was comparing also to standard of care. And there's also the COMPOSE study taking place right now that's comparing lutetium DOTA-TOC to one of several standard drugs. And there are others. There's a trial that's comparing Lutathera to capecitabine temozolomide for pancreatic NETs, a study comparing Lutathera to Afinitor for lung neuroendocrine tumors. So these studies are going to be important to help us to figure out how to best sequence treatments, because right now it's there's very little evidence to base these decisions on.
So it's many options available, and it can really be tailored uniquely to every patient. I welcome any questions about PRRT. We are going to pivot a little bit more deeper into PRRT combinations, but before doing so, any questions or experiences to share from the group?
Dr. Haider, I'll just like to make a quick comment if we don't have a patient. Even I think NETs is such a unique and rare cancer because it's not one disease, it's a spectrum of disease. And the way that's why, we rightly picked zebra as one of our mascots, because just like zebras, no two zebras exact same stripes, no two patients exactly similar. So, even 10 years down the road, if we have multiple trials suggesting one drug might be superior over other, we would still have to really tailor the treatment for individual patients based on their individual tumor biology and the nuances. So I don't think we will ever get to a point like breast cancer, where it's a very pretty straightforward. If you have this subtype of breast cancer, this is the regimen. With the NETs, because of such heterogeneity in the way they present and the morphologies and the gradings and the site of origin and functional, non-functional status, I think there'll be always a room to individualize care for the patients.
Yeah, I agree with that 100%. I mean, the studies, which typically encompass, like you say, a very heterogeneous group of patients, may give us an answer on how average outcomes compare to each other. But you're 100% correct that it doesn't provide insight for an individual. And the problem is that we're talking about not one tumor type or one cancer type, but multiple different ones that we're sort of lumping together because each individual is so rare. And you can't do a study, with a rare subtype that, only can accrue 10 patients. So by necessity, we have to group different subtypes of NETs together for these studies. But it makes it very hard to figure out how, individual groups perform. And like you said, neuroendocrine tumors, I mean, you can look at them according to the different primary sites, differentiation, grade. I mean, these are all, different diseases.
I do have a question sent to me. Is PRRT ever given when there is low or no visible disease after surgical removal? And are there any data available to show effectiveness relative to disease burden in PFS? So, Dr. Starr, the first question is, does PRRT have a role in adjuvant if there is no visible tumor?
So yeah, interesting. So it's timely because there was actually a presentation at ESMO that I was just pulling up earlier on adjuvant Lutathera. I think it was after PNET resection for PNET. I didn't get to dive into it really yet, the presentation. Right now in this November 30th, 2023, there's no role for adjuvant PRRT. The PRRT is a targeted therapy where the cells have to be apparent to be able to kind of go after the cell and attach the target. So if we're in the PET scans are, the sensitivity is incredible on these. We would historically say for a PET scan, for a glucose PET scan, a tumor had to be 1 centimeter, right? But for a somatostatin receptor PET scan, I pick up things that are 2-3 millimeters, right? With that being said, the question for adjuvant therapy is micrometastatic disease, right? Disease that we can't even see. So I don't know. I mean, granted, even if we can't see it, doesn't mean it's not there. It's just hard to imagine the PRRT being overly beneficial in that setting. Although I wouldn't say with 100% certainty that there's no there's no path forward for that approach. Just not something on my radar right now. What about the rest of the group?
I think, Dr. Starr, that study in ESMO was neoadjuvant.
Was it? Okay.
It was neoadjuvant. I think it's an interesting concept. I'm, however, not convinced, because the standard of care right now, and I'm a big believer that if it is a resectable disease, you want to resect it. And unless, of course, if they were, if you have a patient where it is not resectable, it's a borderline resectable, then yes, you want to give neoadjuvant therapies. And traditionally, we do chemotherapies, CAPE-10 being one of them for pancreatic NETs. This study, however, gives us some prospective data on how PRRT in prospective setting, what are the response rates like, etc. However, I think I'm yet to be convinced with that study because, what are we trying to achieve by giving a drug which has a dose limiting factor in the lifespan for the radiation exposure in a patient who otherwise would have gotten just surgery, and we can save this treatment for later. I'm curious to hear Dr. Strasberg's opinion on the neoadjuvant study.
Just to intervene, neoadjuvant meaning before surgery. So a treatment that's designed to prepare for surgery or make surgery more feasible, or perhaps address recurrence after surgery. Go ahead, Dr. Strasberg.
Yes. So I agree. I mean, not all those tumors that were, first of all, the neoadjuvant study was quite small. Second, some tumors might have been converted from unresectable to resectable, but I think in most cases they were probably resectable to start with. And the question of whether this giving treatment before surgery helps reduce recurrence in the future, can't be answered with a small non-randomized study. So You know, it's hard to draw too many conclusions, and we do tend to give chemotherapy more often than PRRT prior to surgery for pancreatic neuroendocrine tumors we're talking about here. That where we think that the surgery may be easier if patients have, or if we're able to shrink the tumors first. You know, regarding tumor burden and response, you know, there is some evidence that larger tumors might not respond as well as smaller tumors to PRRT. And probably a very high tumor burden, patients might not do as well as patients with low tumor burden. At the same time, you know, you don't want to treat patients too early because there are risks, long-term risk with PRRT. There's about a 2% risk of developing leukemia or myelodysplastic syndrome, which are obviously extremely serious complications. In almost all cases, if patients develop them, they're not, you know, they're very, very deadly complications. Now it's rare, but it's definitely something to think about. And there are other side effects. So I don't think you want to treat patients too early. In some situations, they may not even need, you know, to receive PRRT if you know, particularly older patients who have a low tumor volume. So trying to judge the window where it's most appropriate to treat patients and weigh the risks and benefits is very difficult. You don't want to wait too long, but you also don't want to start too early.
Okay. I can quickly answer this next question because we're really having a lot of excellent discussions, and I want to make sure we cover a couple of other topics. But if Sandostatin, somatostatin analog is losing effect, how do you decide between Afinitor or PRRT? Certainly, that question is open and can be tailored. The answer can be tailored to the patient and the tumor characteristics. So, you know, where did it originate from? How does it behave on a PET scan at restaging or new PET scan prior to making this decision? And then what fits best for the lifestyle of the patient? You know, is taking a pill a burden on a very busy person, but can they commit to 4 treatments 8 weeks apart? So it can really be tailored in multiple ways until more studies are done to help us understand if truly there's a superior option that should first be looked at as a second-line treatment. I will get back to the question about histotripsy, but while we are discussing PRRT, Dr. Chauhan, we currently use PRRT on its own. And there's a lot of effort to see if we can use an agent with it to kind of radiosensitize, if you will, or increase the benefit. Can you talk a little bit about forthcoming data?
Yes, thank you, Dr. Haider. So I'm personally, I might be a little biased because I'm very invested in my personal research when it comes to radiation sensitizers and combination therapies with PRRT. When I first got into the field, PRRT was this shining new drug and clearly, you know, transformative for a lot of our patients, and was really very, very exciting to see. I was there, I think 2017 NANETS, and Dr. Strauss was presenting the data for Lutathera. That really wasn't the last stop, though. It was just opening a new gateway, newer pathway toward better this class of drug and how to make it even better now. So Lutathera was a significant advance in terms of how we treat these patients. Just to kind of give a perspective, all the FDA-approved therapies prior to Lutathera, the response rate, that means the capacity to shrink the tumor, was in single digits. You know, somatostatin analog, maybe 4 to 5%. Everolimus, about 7%. So our treatments were primarily cytostatic. That means keep them stable. Even Lutathera does that, essentially, in most majority of patients. However, it really took that response rate to double digits. The current FDA label for Lutathera suggests about 14% response rates. In individual studies that had been reported even higher than that. But I think that's our next frontier. In some patients, there is need for cytoreduction, like your last question, for somebody who's having functional syndrome and is losing control with just somatostatin analog. One of the things we try to do is cytoreduce the tumor, either by embolization, surgery, or if we have effective systemic therapies that might really help us control those syndrome symptoms. So we really need to to kind of take it up the notch and see if we can improve the effectiveness of Lutathera. Can we make it even twice as better? That was the inspiration where we kind of took from Lutathera and kind of tried to make it even smarter and safer. So there are now a lot of studies going on worldwide, definitely in the US, where we are looking at novel agents and combining them with Lutathera to make Lutathera work better. So these agents by itself might not do the heavy lifting. Lutathera is still the main backbone here, but they're trying to make Lutathera work better. So what's the theory behind it? So Lutathera causes the single strand DNA break, right? So the drug, when it's injected, goes find your tumors, attaches to the tumor because it has a somatostatin analog, and then gets engulfed in the tumor, and then radiates the tumor. That radiation causes breaks in the DNA, and the tumor cell dies. Then you might ask me, then why does the tumor cell survive? Why does it eventually progress or grow back? Because the tumor is also trying to fight us, right? It's a fight for the tumor's own survival. So it has ways to repair its DNA. So we are causing DNA damage with Lutathera, but the tumor cell is trying to heal its DNA. So a lot of these combination studies are looking at that DNA repair pathways. And right now, the two key pathways are, the DNA PK protein kinase inhibitors, and other ones, a PARP inhibition that is looking into that. So we presented two of our own studies, which are multi-center NCI sponsored studies, where we are testing a drug called triapine, which is a ribonucleotide reductase inhibitor. From our preclinical data from animal models, the drug seems to be an excellent radiation sensitizer. So we tested it in first-in-human study. I treated about 30 patients, and we were able to present some early data. So one thing we could confirm that, yes, these two things can be combined safely without causing harm to the patient. That was the key objective of this. And what is that safe dose? But secondly, we also wanted to get some sort of early prelim data on, are we seeing signals of effectiveness? Because if it's not really adding to the benefit, why are we even doing it, right? So of course, we cannot comment too much because the study is still ongoing. It has completed the enrollment and we are still following the patient. But, even a year out, I get called from some of the investigators from West goes, hey, my patient's now finally achieved a partial response, right? So these datas are only getting better as we kind of present. So at the time for the data lock for NANETS, we reported about 21, 22% response rates that might be hitting about 25, 27% range as of now. But, based on at least FDA label, we've kind of sort of almost doubled the response rate. Does that mean that it will also mean that it will benefit the median progression-free survival or stability or overall? That we cannot say because it's a small phase 1 study. To answer that question, we are now taking the study into a phase 2 setting. And the phase 2 randomized study is approved. It's already open in a couple of sites, and many other sites are opening it as we speak. And it will enroll 100 patients, 50 in the triapine plus Lutathera arm, and other 50 in the standard of care Lutathera arm. And that study will definitively give us hints that combination does do better. And if that turns out to be the case, we will then take it to a randomized phase 3. So very exciting development there. The fact that it made it to a phase 2 shows that we have confidence in kind of taking this forward. The other study that we are looking at is a brand new drug, is first in its class drug called piposertib. The drug was manufactured in Germany, designed in Germany. It targets a specific enzyme called DNA protein kinase, which is highly specific for the cells where there is a DNA damage. This is not expressed in other cells at all. So when we tested it in our NET models and caused the DNA damage through either chemo or radiation, you'll see a spike in the DNA PK. So you have to then block that enzyme by giving this drug, and hopefully that will slow down the process of the DNA repair. So I'm happy to reveal that study is almost completed. We are like almost, I think, one slot left, and this will complete the 31 patient phase 1 study. And sometime next year, we will kind of reveal the complete data, including some early efficacy data. But we presented the safety data on this And again, we were able to confirm that it can be combined safely, and we were able to find the safe dose. If this ever goes to a phase 2, what would be that safe dose? So those are the 2 studies that we are personally investigating, and it's a multi-center studies. There are some other studies which my colleagues are participating in, and I'm very personally very excited about. One of them is from NIH. Dr. Lin and Dr. Del Rivero are studying PARP inhibitor olaparib in combination with Lutathera. Again, it's kind of going through various dose escalations right now, and so far so good. And I wish them luck, and would like to see the mature data hopefully next year. And another last one in that series is the study combining a drug called cabozantinib. It's a very cool drug, and actually a lot of good press about this drug lately. I think Dr. Strasberg will kind of brief us a little bit in a second. As a really, really exciting study. However, this particular study by Dr. Hagen Kennecke in West Coast is evaluating when you add cabozantinib, which by itself is a pretty good treatment for well-differentiated neuroendocrine tumor, what happened when you add it to Lutathera? Because the rationale there is cabozantinib is a VEGF inhibitor. It blocks new blood vessel formation, which are needed for new tumor growth to feed itself in a very simplistic way. So if you combine these 2, there is some data to suggest that they are synergistic. That is, it's not 1 + 1 2, it's 1 + 1 11 sort of effectiveness. So it's a pretty good preclinical rationale that's now leading to this first-in-human combination, and they presented some early data from some early cohorts. So again, I wish them all the best, and I look forward to seeing mature data next year. So those are the combination studies which are of high priority, high importance, are currently ongoing, and hopefully will take the field forward and will still keep Lutathera or beta PRRT relevant in the era of alpha PRRT.
Or future combinations with alpha as well, as that
There you
continues to grow.
Exactly. Absolutely.
It's a small but mighty field in neuroendocrine, which is really exciting.
Absolutely.
Right.
Any comments from Dr. Starr or Dr. Strasberg about those? To add? Okay.
No, thanks for leading the charge there, Dr. Chauhan, with these radiosensitizers.
Thank you, Dr. Starr.
We can pause here for a moment to see if there are any questions about these combinations, or anyone looking at trials wants to share their experience. I want to actually pivot over to Dr. Strasberg, since you brought up cabozantinib. And I'm also very excited, because I think within the discussions we've had, this is the most tangible, immediate addition to our treatments for well-differentiated, more mature, lower-grade tumors. So can you share the CABINET trial, which we had here as well at Moffitt?
Sure. Thanks. So the CABINET trial was a phase 3 study looking at cabozantinib, which is a drug it's a so-called targeted drug. It targets the vascular endothelial growth factor receptor, which many cancers express on the cell surface, and that contributes to blood vessel growth in tumors, as well as some other receptors such as c-MET, RET. These are, again, receptors that are on the cancer cell surface. So this targets and blocks them. And it's been shown to be active in phase 2 trials in neuroendocrine tumors. And so this was a phase 3 study looking at patients with progressive, well-differentiated neuroendocrine tumors. Any grade actually was allowed. So from grade 1 all the way to grade 3, but it had to be well-differentiated. Patients had to have had at least one line of treatment beyond a somatostatin analog. And in many cases, they had had several lines of therapy in the past. And it was a placebo-controlled study. So patients were randomized either to the active drug or to basically a sugar pill, but with the possibility of crossing over and receiving the active drug after the tumors grew, after progression. And so the primary endpoint, as it is for most neuroendocrine tumor randomized trials, was progression-free survival, meaning basically time until the tumor grows, until the cancer grows significantly. And the study met that endpoint. On the placebo arm, the average time to tumor growth was 3 months, both in patients with pancreatic neuroendocrine tumors and also patients with gastrointestinal and lung neuroendocrine tumors. but it increased significantly with cabozantinib. So for the gastrointestinal lung neuroendocrine tumors, increased from 3 months to about 8 months. For patients with pancreatic neuroendocrine tumors, there was even a greater benefit. It went from 3 months to about 11 months. So more than tripled the time until tumor growth. As far as tumor shrinkage, the response rates were, not high. It was about 5% for the gastrointestinal and lung nets. It was a little bit higher, I think about 15%, or 18% for pancreatic neuroendocrine tumors. And that's often the case that pancreatic neuroendocrine tumors respond better than non-pancreatic primaries to all sorts of different treatments, including chemotherapy and targeted drugs. There wasn't much of a survival difference between the active arm and the placebo, but we can explain that by the fact that almost anyone who progressed on placebo ended up crossing over and receiving the active drug. As far as side effects, it's not that dissimilar from Sutent, which is an older drug that was approved years ago for pancreatic neuroendocrine tumors. So it can cause high blood pressure, tiredness, sometimes a painful rash on the hands and feet, diarrhea. It can increase blood pressure. It can slightly increase the risk of cardiovascular events. So we have to be careful in patients with history of coronary artery disease or history of strokes. The tiredness, I would say, is the biggest side effect. Most people need to have dose reductions from the standard 60 milligrams to go down to either 40 or 20 milligrams to be able to tolerate this drug in the long term. But, it's great that we have a drug that's, was found to be active in a large phase 3 trial. And I'm not sure whether it's going to be FDA approved or not. It was not a FDA pre-registered trial, but I think the company is going to go to the FDA to try to get approval. But even if it's not approved, it's a drug that's already approved for other cancer types, and it will almost certainly be guideline recommended by various organizations like the NCCN. So I think it will be both available to patients and covered by insurance in most cases.
Thank you. I think the next question would be, where would we fit this in all of the options? And I think it's that personalized approach again.
Right.
We have a few more minutes left, and it is not enough to discuss neuroendocrine carcinoma, but I do want to take some time with what's new in these high-grade tumors. Before that, Dr. Chauhan, I want to answer the question about histotripsy. Due to time, we won't delve into this today, but that was our discussion at our last webinar where Dr. Al-Haddad really spent some time reviewing this, and it is saved on the FLaNET website. So please review that, and then please send us questions, and we'll bring this topic back to our future webinars. So Dr. Chauhan, we've really focused our discussions on PRRT, where neuroendocrine tumors can express these targetable receptors, and some systemic therapies to augment that, maybe some ongoing systemic therapies really more geared toward well-differentiated tumors. But we, want to expand on the neuroendocrine carcinoma front as well. Historically, we're using chemotherapies. There's a role for perhaps immune therapy or combination with ongoing trials. What have you seen at NANETS this year that's expanding the treatment algorithm here?
Right. This is truly, in real sense, a critical unmet medical need. Metastatic patients, median survival in a year and a half, which is a completely different disease. Probably, I call them leukemia of solid tumors, right? Very rapidly growing cancers. So finally, after years, I guess there's some ray of hope. There are some exciting compounds being developed. The most promising one probably would be the DLL3 BiTE agent. So just briefly, high-grade neuroendocrine cancers, be it in the lung, like small cell lung cancer, or outside lung, large or small cell cancer, they express this protein called DLL3, delta-like ligand, on their surface in a very decent amount of quantity. And there is a drug, which is an antibody. It has two arms, and one arm attaches to the DLL3, which is on the tumor, and the other arm attaches to the T cells, the immune cells, the patient's own immune cells. So it's an immunotherapy drug, and it brings your immune cells closer to cancer cells, and then makes your own immune system fight against cancer. So that's a general concept. This in 2023, various meetings, including ASCO, ESMO, and our own NANETS, we saw data from phase 1 studies from various manufacturers, Rocket Pharmaceuticals, Amgen, and BI, revealing data, especially Amgen and BI data looks exciting from phase 1, where we're seeing response rates from all the 30 to 40, 45, 50% in a disease type with a very poor prognosis, in the disease type where the traditional refractory treatments have response rate of 10% or less. So it's very, very exciting to see. And it's not just the response, it's the duration of response. The patients who have done well to this agent, they tend to seem have a lasting effect, which is sort of emblematic for these immunotherapy-based treatments. I've personally participated in some of these studies when I was in Kentucky in the early phase study. So I've seen the profound effect they can have on the patients who do respond to these. So the field is, looking forward. I think these agents going to now move to phase 2s and phase 3 settings, and you will see not one, but multiple of these studies testing in frontline, second line, refractory, combination with chemotherapies, etc. So I think DLL3 by targeting is definitely up and coming, is something to keep an eye on and probably might lead to a breakthrough in our field. There were some other agents that are being investigated, especially from small cell lung cancer world, which was presented World Lung Meeting. That's where we usually get a lot of our inspiration, and we kind of then take it to our extrathoracic high grades. So combination VEGF and immune checkpoint inhibitor had a positive study even for overall survival in China. It'll be very interesting to investigate that concept in the Western population in both thoracic as well as extrathoracic high-grade neuroendocrine cancers. Other agents being looked at is PARP inhibition in combination with checkpoints. So Dr. Nagla Karim presented some of the small cell data with some encouraging prelim results, and we presented some data at NANETS and AACR using rucaparib and nivolumab as a maintenance strategy in frontline and high-grade neuroendocrine cancers. So again, there's a lot of really exciting drug development happening with DLL3 BiTE probably taking the prize right now.
And I think it's kind of expanding out of chemotherapies, especially with second and third line chemotherapies, as you said, being not as effective as we'd like to see. Anything to add, Dr. Strasberg, Dr. Starr?
No, we're overdue for something besides platinum and etoposide. So please, God.
Right.
We do have a couple of trials here at Moffitt for first line and in the future second line. And I want to highlight that we're very proud and happy to have so many centers dedicated to neuroendocrine oncology in our state. We live in a large state, and there's a struggle to access care. And so with us being spread out and able to provide clinical trials and expertise, it's a really wonderful thing to see. We're also very collaborative. So, we're in contact outside these efforts for FLaNET in building trials and programs together. And we try to diversify our clinical trials throughout the state so that, we can serve in every way possible. I'm also very excited to see so many participants today. I think this is the largest webinar.
Yeah.
Well, thank you
Great
everyone
turnout.
for your time.
Right.
There is a link to the webinars in the chat for your reference. We have a minute. Any last minute question is absolutely welcome.
Yeah, I just want to say thanks for having me, and I agree. In the spirit of collaboration, it's so nice to get together and share ideas. And I just want the patients to know that we're always working for them, and we're here for them. We're accessible to the extent that we can be, and we want to make sure they get the best care. Period.
I completely echo Dr. Starr's sentiments. It's so good to have one of the things I'm learning, because I'm relatively new here, even within Miami, such spread out place, people don't like to travel, right? So it's good to have at least distinct centers, different sides of the state. And we all consult with each other, because we can't really all open all the studies because these are very resource intensive cancer centers. So if I have a patient, I always call Dr. Starr, Dr. Strasberg, hey, do you have something to offer, and vice versa. So we are all very collaborative, and and it's really a win for patients that they have access to not one but multiple NET focused multidisciplinary programs in the state.
All right, last reminder before everyone goes on with their day, we do have our annual in-person meeting. It will be in Miami, University of Miami. Dr. Chauhan is helping host this. Everyone and their families are welcome. And so please look for updates.
Yes, hope to see you there.
I'll
Thank
be
you.
there.
Bring your party hats.
Yes, and your neon clothes.
Thank you,
All right, guys.
everyone.
Thank you. Thank you so much. Have a great day.
Bye.
Bye.
Thank you.
Thank